Okay, so we'll continue the discussion as we were discussing the biomechanical preparation with its three main steps. That is, first is the access cavity preparation, second one is the cleaning and shaping of the canals, and third one is the three-dimensional root canal obturation. So, in the cleaning and shaping, we discussed the shaping techniques. Now, we'll be discussing the irrigants. Irrigants play a very important role in shaping, in cleaning of the root canal system. So, we'll be discussing different irrigants here. We'll continue the discussion. In this, we'll be discussing isotonic saline, sodium hypochlorite, chlorhexidine, hydrogen peroxide, carbamide peroxide, chelators, then antibiotics, ultrasonics, a small introduction to them, then types of needles, then method of use, lasers, and electromechanically activated water, and conclusion. So as we move forward, the use of irrigating solution is an important part of an effective chemomechanical preparations. It gives it involves the antibacterial agent. It aid in debridement of the root canal system. It has the ability to dissolve necrotic tissue or debris. It has low toxicity level, good acts as a good lubricant. It shows low surface tension, ability to sterilize the canal and prevent dissolution of the smear layer. It inactivates the endotoxins produced by the bacteria. So, variables affecting the irrigation. The concentration of the irrigant, the volume of the solution used, the canal diameter, the viscosity or surface tension of the solution which we are using, the diameter and depth of penetration of the irrigating needle, the anatomy of the canal, the method of delivering the irrigant, the contact time with the tissue, temperature of the irrigant, ultrasonic activation, the effect of combining different types of solutions. So when we come to history, till 1900, water was used as an irrigant. In 1914, Dakin solution, that is 5.5% sodium hypochlorite, was used in dentistry. In 1920, Guthrie used sodium hypochlorite in dentistry. In 1930, proteolytic enzymes used for their tissue dissolving action. In 1940, 30% hydrochloric acid and 50% H2SO4 were used. In 1943, Grossman gave concept of using sodium hypochlorite plus 3% H2O2. Then in 1957, EDTA by Nygaard was given. In 1960, RC-PrEP and glyoxide were prepared and used as irrigants. In 1970, chlorhexidine gluconate was used as an endo-irrigant. In 1971, Buchman and Johnson first used carbon dioxide for irrigation. In 1996, use of ECA water as irrigant was done, and in 2003, MT80 was introduced. So we'll be discussing isotonic saline. It provides gross debridement and lubrication, available in 1 liter intravenous container, 2 mild to thoroughly clean the canals, used in the cases of sodium hypochlorite accident. Sodium hypochlorite. It is an antibacterial agent. It dissolves the vital and non-vital tissue. It lubricates. It helps in lubrication during instrumentation. Sodium hypochlorite has been criticized for unpleasant taste, relative toxicity, and inability to remove the smear layer. Mechanism of action of sodium hypochlorite: ability to oxidize and hydrolyze cells to some extent, osmotically draw fluids out of the cells due to its hypertonicity. Sodium hypochlorite has a pH of approximately 11 to 12, and when hypochlorite contacts tissue, formaldehyde and acetaldehyde are formed with a short time and peptide links are broken, resulting in dissolution of the tissue. During the process, hydrogen in the amino groups is replaced by chlorine, thereby forming chloramine, which plays an important role in antimicrobial effectiveness. This is a picture. So questions concerning the use of sodium hypochlorite involves appropriate cement, appropriate concentration of it, method of delivery, and cellular damage caused by the extrusion into the periradicular tissue. In vitro antibacterial studies, we will be discussing some studies. Then high resistance of E. faecalis and high susceptibility of Candida albicans to sodium hypochlorite was seen. C. albicans was killed in vitro in 30 seconds by both 5% and 0.5% sodium hypochlorite. E. faecalis was killed in less than 30 seconds by 5.25% solution, while it took 10 and 30 minutes for complete killing of the bacteria by 2.5% and 0.5% solutions. By Radcliffe et al. in by Bistrom and Sundquist, no significant difference in antibacterial efficiency in vivo between 0.5% and 5% sodium hypochlorite solution was seen. When we come about the concentration, Pachler et al. Compared the biological effects of the mild and strong sodium hypochlorite solution and demonstrated greater cytotoxicity and caustic effects on healthy tissues with 5.25% sodium hypochlorite than with 0.5 and 1% solutions. Trepandier et al. In 1977 concluded either 5.25% or 2.5% sodium hypochlorite has the same effect when used in the root canal space for a period of 5 minutes. 5% sodium hypochlorite may be too toxic for routine use. They found that 0.5% sodium hypochlorite solution dissolves necrotic but not vital tissues and has a considerably less toxicity than a 5% solution. They suggested that 0.5% sodium hypochlorite be used in endodontic therapy. Murrow W.R. et al. And Senia S. et al. Concluded that it must be realized that during irrigation, fresh hypochlorite consistently reaches the canal system and concentration of the solution may thus not play a decisive role. Unclean areas may be a result of the inability of the solutions to physically reach these areas rather than their concentration. Based on the currently available evidence, there is no rationale for using hypochlorite solution at concentration over 1% weight by volume by Joe in 2006. As the proteolytic effect is dependent on the amount of free available chlorine that is used during the process by reacting with inorganic reducing substances, frequent irrigation with a lower concentration may achieve as much of a proteolytic effect as the use of a higher concentration. Therefore, an adequate concentration of sodium hypochlorite to be used for endodontic irrigation may be 0.5 to 1%, with the pH close to neutral has optimal antimicrobial effectiveness with minimal tissue irritating effect. But back in 1950, increasing the efficacy of hypochlorite solution, lower their pH, increase the temperature of low concentration sodium hypochlorite solutions. Bactericidal rates for sodium hypochlorite solutions are more than doubled for each 5% rise in temperature, 5-degree rise in temperature in the range of 5 to 60 degrees centigrade. Then ultrasonic activation is important. So when we discuss about the efficacy of sodium hypochlorite, with the increase in volume, with the increase in heating or temperature, and with the increase of time of contact, its efficacy increases. And when we come here, with the decrease, it starts decreasing when the storage time is more and chemical agents are being more added. So this is the picture depicting how to when we increase the temperature, its effectiveness increases. Is sodium hypochlorite equally effective in dissolving vital, non-vital, or fixed tissue? Rosenfeld et al. In 1978 demonstrated that 5.25% sodium hypochlorite dissolves vital tissues. Hand et al. In 1978 demonstrated as a necrotic tissue solvent, 5.25% sodium hypochlorite was found to be significantly better than 2.6%, 1%, or 0.5%. 3% sodium hypochlorite was found to be optimal for dissolving tissue fixed with parachlorophenol or formaldehyde. The dissolving efficacy of sodium hypochlorite is influenced by the structural integrity of the connective tissue components of the pulp. If the pulp is already decomposed, it won't take long to dissolve the remaining soft tissue remnants. If the pulp is vital and little structural degeneration has occurred, it will take longer for the sodium hypochlorite to dissolve the remnants. Sodium hypochlorite and calcium hydroxide. Hasselgren et al. In 1988 demonstrated that pre-treatment of the tissue with calcium hydroxide can enhance the tissue dissolving effect of sodium hypochlorite. Warachi et al. In 1998 concluded that combination of calcium hydroxide and sodium hypochlorite was more effective on the dissolution of the soft tissue on the root canal walls than using either medicament alone. Then sodium hypochlorite and EDTA or H2O2. EDTA and citric acid strongly interact with sodium hypochlorite to reduce the available chlorine, rendering the hypochlorite ineffective on bacteria and necrotic tissue. The bubbling effect or effervescence chemical reaction is seen. Oxygen evaporates from the aqueous peroxide, hypochlorite mixtures, and chlorine, and oxygen gas from the mixture of sodium hypochlorite with EDTA or citric acid. The adverse effects of sodium hypochlorite. In adjuvant injection of sodium hypochlorite into the soft tissues, amount of destruction depends on host response, volume of irrigants, concentration of irrigant, temperature of irrigant, spread of solution. How to recognize a sodium hypochlorite accident? Immediate severe pain is observed for 2 to 6 minutes. Ballooning or immediate edema in the adjacent soft tissue because of perfusion to the loose connective tissue. Extension of edema to a large site of the face such as cheeks, periorbital region or lips. Ecchymosis on the skin or mucosa as a result of the profuse interstitial bleeding. Profuse intraoral bleeding directly from the root canal. Chlorine taste or smell because of the injected sodium hypochlorite to maxillary sinus. Severe initial pain replaced with a constant discomfort or numbness related to tissue destruction and distension. Reversible or persistent anesthesia. Possibility of the secondary infection or spreading of the former infection. Then how to treat a sodium hypochlorite accident. Remain calm and inform the patient about the cause and nature of the complication. Immediately irrigate with a normal saline and to decrease the soft tissue irritation by diluting the sodium hypochlorite. Let the bleeding response continue as it helps to flush the irritant out of the tissues. Recommend ice bag for compression for 24 hours, 15 minutes intervals to minimize the swelling. Recommend warm, moist compress after 24 hours, 15 minutes intervals. Recommend rinsing with the normal saline for 1 week to improve the circulation of the affected area. For pain control, initial control of the acute pain could be achieved with anesthetic nerve block. Acetaminophen-based narcotic analgesics for 3 to 7 days, that is NSAID analgesics, should be avoided to decrease the amount of bleeding into the soft tissue. Prophylactic antibiotic coverage for 7 to 10 days to prevent secondary infection or spreading of the present infection. Steroid therapy with methylprednisolone for 2 to 3 days to control inflammatory reaction. Daily contact to monitor recovery. In severe cases such as respiratory distress, accessing the local emergency service via 9 is appreciated. Reassure the patient about the lengthy resolution of the inflammatory reaction. Provide the patient with both verbal and written home care instructions. Monitor the patient for pain control, secondary infection, and reassure. VDA, bis-diqualinium acetate. It has low toxicity, lubrication action, disinfecting ability, low surface tension, chelating properties, low incidence of post-treatment pain. This dequalinium acetate is recommended as an excellent substitute for sodium hypochlorite in those patients who are allergic to the latter. Chlorhexidine, cationic biguanide, acts by absorbing onto the cell wall of microorganisms. It has when in low concentration, it is bacteriostatic. When in high concentration, it is bactericidal. Optimal antimicrobial activity, pH of 5.5 to 7. Substantive antimicrobial activity or substantivity is there. Its activity is pH dependent and is greatly reduced in the presence of organic matter. 2% endodontic irrigant, 2% of it is used as an endodontic irrigant. Now, advantages of using chlorhexidine gel over solution. It promotes a better mechanical cleansing of the root canal and better removal of the dentine debris, good antimicrobial activity and a lubricant action during instrumentation, which leads to less stress on the rotary file to see. Picture depicting in vitro the antibacterial effect of the chlorhexidine. In vitro, chlorhexidine is superior to sodium hypochlorite in killing of E. faecalis and Staphylococcus aureus by Gomes et al. In 2001, on Cag et al. And Viana et al. Chlorhexidine effectively kills C. albicans. It was proven by Bartwall et al., Hume et al., Hammers et al., and Garlevito et al. Baltimore. Can chlorhexidine be used as a final irrigant? 2% chlorhexidine solution used as a final irrigant significantly decreased bacterial loads in root canals that had been treated with sodium hypochlorite during biomechanical preparation. Despite its despite its usefulness as a final irrigant, chlorhexidine cannot be advocated as the main irrigant in standard endodontic cases because it is unable to dissolve the necrotic tissue remnants, less effective on the gram-negative than in gram-positive bacteria. Chlorhexidine and H2O2. In vitro, 3% H2O2 and chlorhexidine was superior in its antibacterial activity compared with other regimens such as chlorhexidine alone and sodium hypochlorite by Hilling and Chandler 1998. The combination of the two substances totally killed E. faecalis in concentrations much lower than each component alone by Stenberg et al. It can be postulated that the exposure of the bacteria to chlorhexidine leads to a more permeable cell wall that H2O2 can penetrate easily and hence damage the intracellular organelles. Chlorhexidine and calcium hydroxide. Calcium hydroxide mixed with chlorhexidine gel had better antimicrobial activity than calcium hydroxide manipulated with sterile water in an in vitro study by Gomes et al. Siren et al. Concluded that calcium hydroxide was unable to kill E. faecalis in dentine, but calcium hydroxide combined with chlorhexidine effectively disinfected the dentine. When we come to H2O2, it is a clear, colorless liquid. 4% endodontic irrigant. 4% of it is used as an endodontic irrigant. H2O2 is active against viruses, bacteria, and yeast. It produces hydroxyl free radicals, which attack several cell components such as proteins and DNA. In endodontics, H2O2 has long been used before because of its antimicrobial and cleansing properties. It has been particularly popular in cleaning the pulp chamber from blood and tissue remnants, but it has also been used in canal irrigation. Grossman recommended alternate use of 3% H2O2 and 5.25% sodium hypochlorite as irrigants. Advantages: effervescence or foaming action results from the chemical reaction. This strongly suggested for irrigating canals of the teeth that have been left open for drainage because the effervescence is effective in dislodging food particles as well as other debris that may have packed the canal. Note: H2O2 should not be the last irrigant used in a canal because nascent oxygen may remain after access preparation, closure, and build up the pressure. Therefore, sodium hypochlorite should be used to react with H2O2 and liberate the oxygen remaining. Then the canal is dried and closed. Carbamide peroxide. Available in any anhydrous glycerol base glyoxide to prevent decomposition, better tolerated by periapical tissue and more germicidal than hydrogen peroxide. Excellent irrigant for treating canals with normal periapical tissues and wide apices. Narrow or curved canals utilizing the slippery effect of glycerol. Now the chelating agent. Organic substances that remove ions, such as calcium, by binding with them and chemically aids in instrumentation. Most widely used is EDTA, ethylene diamine tetraacetic acid, by Nygaard by 1957. Chelator preparations, liquid chelator and paste type chelator. REDTA, 17% EDTA solution plus 0.84 grams cetyl trimethyl ammonium bromide to reduce surface tension. EDTA-T, 17% EDTA plus sodium lauryl ether sulfate as detergent. EDTAC, 15% EDTA plus 0.75 gram of cetyl trimethyl ammonium bromide. Greater germicidal activity but greater inflammatory potential to tissue as well. DTPAC, diethyl triamine pentacetic acid, cetyl plus cetyl trimethyl ammonium bromide, EGTA, ethylene glycol tetraacetic acid. CDTA, 1% solution of the cyclohexane 1,2-diamine tetraacetic acid. Larval Ultra, 15% EGTA as this disodium salt plus 0.75 cetyl 0.75% cetyl trimethyl bromide and sodium hydroxide. Salvizol, 5% amino phenylidinium diacetate in propylene glycol has a pH of 6.6%. Sorry, 6.6. Then Publicid plus 1.5 gram amphoteric 2.5 gram benzalcanic chloride, 3 grams with sodium EDTA dihydrate, 100 grams distilled water and 50% citric acid. Lardil solution, 5% sodium hypochlorite plus 70% EDTA plus HYPAC. HYPAC is an aqueous solution of two iodide salts, diatrizoate, meglumine, and sodium iodine. It is a water soluble and has a pH of 6 to 7. This agent is intended to visualize the complexity of the canal system and thus to combine the solving potential of EDTA and sodium hypochlorite and the radiopacity of the contrast solution. Paste type chelators, RC prep, 15% EDTA plus 10% urea peroxide in aqueous solution. Urea peroxide retains its antibacterial action in the presence of blood. The glycol component serves as the lubricant for instruments and is thought to inhibit the oxidation of EDTA by urea peroxide. Phi2E is a chelating agent in an aqueous water soluble solution containing 19% EDTA. So EDTA has little, if any, antibacterial activity. EDTA 15% to 17% is effective. It effectively removes smear layer by chelating the inorganic components of the dentine, aid in mechanical canal shaping. EDTA chelates with calcium ion and other divalent cations, demineralizes the dentine, and removes the inorganic components of the smear layer. EDTA chelation is known to be time and pH dependent. So pH determines the ratio of ionized to non-ionized forms of EDTA in solution, as well as limiting the concentration that can be achieved. Optimal pH is 6 to 10. As pH increases, the availability of the calcium ions from hydroxyapatite for chelation decreases. At the same time, a greater dissolution of the EDTA produces an increased attraction for calcium ions. At lower pH, the calcium ion becomes more available for chelation, but the efficacy of EDTA decreases. At pH 7.5, a 10% solution released twofold less phosphorus in 1 minute than a 17% solution, and EDTA was more effective at a neutral pH than at pH 9. Time, Goldberg and Spielberg showed that optimum working time for EasyTac is 15 minutes. Yamda et al. Concluded a few seconds of ETA is sufficient. Marion et al. Says smear was completely removed with 10% EDTA for 1 minute, resulting in increased tubular orifice size. Sorry. Koznetzer et al. Noted similar results when 15% EDTA was applied in root canals for 4 minutes. Chalt and Serper, when 17% EDTA, pH 7.4 was applied for 10 minutes, excessive erosive effects with dissolution of peritubular and intertubular dentine was seen. Phosphorus releasing effect of EDTA rapidly rises to a level within 1 minute, and further exposure of EDTA only doubled its effect upon 15 minutes of further administration. RC prep. RC prep is composed of EDTA and urea peroxide in a base of carbovax. It is not water soluble. Sodium hypochlorite and RC prep are and RC prep. Interaction of the urea peroxide in RC prep with sodium hypochlorite producing a bubbling action thought to loosen and help float out the dentinal debris. Talbizol. Based on the dihemi-potassium salt, which increases the solubility of the hydroxyapatite crystals in reduced time. Highest resolution of the tricalcium phosphate with pH 6. Although 3-minute irrigation allowed better smear elimination, a 1-minute application of low concentration solution was sufficient to open the dentinal tubule. Organic acids. Wayman et al. Reported excellent filling results after preparation with citric acid, 20%, followed by 2.6% of sodium hypochlorite, and a final flushing with 10% citric acid. Polyacrylic acid as a Duralon and Pseudo-2 liquids, both 40% and polyacrylic acid were used. Suggested irrigating regime: 10 milliliter of 5% sodium hypochlorite plus 10 milliliter of the 17% EDTA. EDTA acts an inorganic component called decalcification of peri and intertubular dentine and leaves collagen exposed. Subsequently, sodium hypochlorite dissolves collagen, leaving the entrances to the dentinal tubules more open. By Goldman et al., Matter, Yamda et al., Abbott et al., etc. So we come to now antibiotics. Tetracycline hydrochloric acid, minocycline, and doxycycline. Bacteriostatic in action, low pH, calcium chelators, and cause enamel and root surface demineralization. Substantivity. Markharder et al. Stated that doxycycline HCl 100 mg per milliliter is effective in removing the smear. BioPure MTAD 3% doxycycline hyclate shows the antibacterial action. 4.25% citric acid removes the organic and inorganic substances. 0.5% polysorbate 80 detergent acts as a surfactant. Antibacterial activity, it has low pH 2.15 of 2.15 and shows substantivity. Antibacterial effect, uh, so here substantivity means the prolonged association between a material and a substrate. Okay, so antibacterial effect in vitro study. The antibacterial effect of MTAB, sodium hypochlorite, and EDTA were compared using a disk diffusion test on agar plate. The results show that even highly diluted MTAB produces clear zones of inhibition of the test bacterium E. faecalis. Shabang et al. In 2003 stated that in vitro study, the effect of MTAD on the root canals contaminated with either saliva or E. faecalis was evaluated and reported good antibacterial activity. Cytotoxicity. Zhang et al. In 2003 stated that cytotoxicity of MTAD was evaluated on fibroblasts. MTAD is less cytotoxic than eugenol, 3% sodium 3% of sodium peroxide, calcium hydroxide paste, 5.25% sodium hypochlorite, Peldex or chlorhexidine mouthpins with additives, and EDTA, but more cytotoxic than 2.63%, 1.31%, and 0.66% sodium hypochlorite. MTAD and sodium hypochlorite, no significant differences between the ability of 1.3% and 2.6% and 5.25% as the root canal irrigants with MTB as a final rinse to remove the smear layer. It seems prudent to use the lowest concentration of sodium hypochlorite, that is 1.3% during the instrumentation, followed by MTAD by Tora Binajat 2003. Now, iodine in potassium iodide. Iodine in potassium iodide, useful in retreatment cases where E. faecalis has survived, used as 2% solution of iodine in 4% aqueous potassium iodide. Churchill solution, iodine 16.5 gram, potassium iodide 3.5 grams, distilled water 20 grams, ethanol 90%, 60 grams. Presence of smear layer decreases the effectiveness of the solution. Surface tension, force between molecules that produces a tendency for the surface area of a liquid to decrease. This force tends to inhibit the spread of a liquid over a surface or to limit its ability to penetrate a capillary tube. The efficiency of an endodontic irrigant could therefore be improved by reducing its surface tension. Above Rath and Patoni found that the chemical polysorbate 80 reduced the surface tension of distilled water, alcohol, sodium hypochlorite, and EDTA by 15 to 20%, thereby enhancing the flow and penetration of the test solutions into the canals in vitro. Cameron has shown the surface tension of 4% sodium hypochlorite to be reduced from 70 nm to 27 by addition of 0.1% fluorochemical surfactant, fluoride FC99. Cetirizine, cetirizine 0.2% chlorhexidine gluconate and 2.2% cetrimide. Ultrasonic irrigation, a small introduction for this, which is important for which is used for activating the irrigating solution. The flushing action of the irrigant solution may be more important than the ability of the irrigant solution to dissolve tissue by Baker et al. Most of the dentine debris is inorganic matter that cannot be dissolved by sodium hypochlorite solution. Therefore, removal of the dentine debris relies mostly on the flushing action of the irrigant. The enhancement of the flushing action of an irrigant solution by using ultrasound is well documented by Cunningham and Martin in 1982, Cunningham et al., etc. The ultrasound device allowed the endodontic irrigant to pass along the ultrasonic files. The irrigant is activated by the ultrasonic energy impaired from the energized instrument, producing acoustic streaming and eddy. Cavitation. When ultrasonic file vibrates in a liquid to produce alternating compressions and refractions of pressure, a negative pressure develops within the exposed cells of the intracanal materials, pulp, tissue, bacteria, debris, metabolites. This causes an implosion or inward explosion that breaks these cells apart inwardly and leads to their destruction. Acoustic streaming, process by which the vibrating file generates a stream of liquid to produce eddies and flows of oscillation. The dimension of these eddies and flows around the file are consistent and reproducible. Cunningham and Martin in 1982 and Cunningham et al. In 1982 stated that more bacterial spores and dentine debris were removed during ultrasonic irrigation than hand irrigation. A file is placed in the canal, ultrasonic activation is done, which causes the acoustic streaming. It increases the mechanical energy which is being produced dislodge the debris from the canal, and the warming effect helps in cleaning the wall. Types of endodontic needles, bevel needles. The first picture shows the bevel needles. Irrigant folds apically. There is a risk of extrusion if the needle becomes lodged in the canal. Then the second one are the monojet tip. Irrigants can pass sideways, and safe ended tip. Irrigant passes sideways. Monojet endodontic needles to be the most efficient delivery systems in which longer needles of a blunted open-end system were inserted to full length of the canal. Larger volume of the solution can be delivered. However, the closer the needle tip is placed to the apex, the greater the potential for the damage of the periarticular tissue is there. Pro risk. It has closed end and side vented, which eliminates possibilities of puncture of the apicus foramen or a water cannon effect from open end needles. Expression of the fluid through the lumen creates turbulence around and beyond the end of the flow. The most important factor is the delivery system and not the irrigating solution per se. The volume of the irrigant is more important than the concentration or type of the irrigant by Bolton and Sorabinajad. In order to be effective, the needle delivering the solution must come in close proximity to the material to be removed. Small diameter needles were found to be more effective in reaching the adequate depth, but were more prone to problems of possible breakage and difficulty in expressing the irrigant from the narrow. Now the method of use. It is strongly recommended that the needle lie passively in the canal and not engage the walls. The solution must be introduced slowly The irrigating needle should be bent to allow easier delivery of the solution and to prevent deep penetration of the needle. Care must be taken with irrigants like sodium hypochlorite to prevent the accident. This is the method. We should bend the needle and endosonic. Most portable ultrasonic units can be fitted with an endosonic file attachment that allows the delivery of the irrigant. Ensure penetration of the irrigant into the lateral canal, fins, and anastomosis where files cannot penetrate. Ultrasonically energized file creates currents of streaming of irrigants within the root canal. Notes can be seen along this file as it vibrates in the air. Now the lasers. The emitted energy can be delivered into the root canal system by a thin optical fiber and diag or via SGG laser, argon and diode or by a hollow tube, carbon dioxide or ERGAG laser. Limitation: laser energy directed along the root canal and not necessarily laterally to the root canal wall. Thermal damage to the periapical tissue. Photoactivated disinfection, low power visible red semiconductor diode lasers and toluidine blue dye are used. Electrochemically activated water or oxidative potential water. When electrolysis of an aqueous saline solution is carried out in an EAW unit, an anolyte and a catholyte of electrochemically activated water are produced and isolated. The former is antimicrobial, has a high oxidation potential and pH of between 2 and 9. When the anolyte and catholyte were individually used to irrigate infected canals, the antimicrobial effectiveness was disappointing when compared with 0.5% sodium hypochlorite. A newer solution called electrolyzed neutral water produced a solution with a pH close to 7. This solution was bactericidal against the selection of commonly isolated endodontic pathogens. An alternative solution, termed oxidative potential water, has been found to be highly antimicrobial because of its acidity and high oxidation reduction potential. This solution has been shown to remove smear layer and debris when used to irrigate root canals. Sterilox is a commercially available unit that produces anolytes and catholytes from a quality controlled pre-packed solution. The main active ingredient that is produced by the Sterilox generator is 85 to 95% hydrochlorous acid. This agent is very effective biocide but is also non-toxic, non-sensitizing, non-irritating and non-mutagenic. The conclusion: endodontic disease is mediated by bacteria. Treatment goals should be directed to reducing the critical concentration of the microbial irritants to the lowest level possible. Thorough canal instrumentation with either stainless steel hand files or nitrile rotary files removes the bulk of the tissue and microbial contamination, but adjunctive chemical agents are needed to optimize debridement. Current concepts support the following approaches: lubricating and chelating agents during cleaning and shaping, copious irrigation during all the phases of instrumentation with 2.5% sodium hypochlorite, constantly refreshed, deep penetration of a side port, narrow gauge irrigating needle, constantly moving in and out of the canal space during each irrigation, removal of the residual smear layer at completion of instrumentation prior to obturation. Thank you. Where we complete with this.